Thank you very much, dear Luke, for the introduction. First of all, I would like to thank the meeting organizers, the IAMMF, and especially Helen for allowing me to be here and see many friends and colleagues. I want to take also the opportunity to thank the patients and caregivers for your voice, your testimony, and your courage. It's really impressive, and this really pushes us to do better, do faster. And as you can see, you are not walking alone. There is a growing community working with you, and for all of us. So please be brave and positive. Well, this is a teamwork. So in this presentation, I will focus on next generation liquid biopsy biomarkers for cholangiocarcinoma. These are my conflicts. Well, as you know, most of the patients with cholangiocarcinoma are asymptomatic in early tumor stages and are commonly diagnosed in advanced phases when the disease is usually widespread. In this regard, the diagnosis of cholangiocarcinoma is an incidental finding in around 25% of the cases, and the patients might experience some unspecific symptoms that can prompt the diagnosis, like jaundice, fever, severe weight loss, fatigue, and abdominal pain. The diagnosis of cholangiocarcinoma is usually conducted by a sequential combination of imaging techniques, the analysis of non-specific tumor markers in serum, such as CA19 and CEA, but finally, a histological examination of tumor biopsy is necessary to confirm the diagnosis. So current non-invasive modalities based on imaging of biochemical biomarkers are suboptimal for the early detection of cholangiocarcinoma, for the differential diagnosis of the different types of liver cancers, and also for the differential diagnosis between benign and malignant biliary strictures. And tumor biopsy, as you know, is invasive with inherent risk. So we need to do better. We need better biomarkers, and particularly non-invasive biomarkers. Well, as it was mentioned, the analysis of CA19 and CEA is commonly used to help in the diagnosis of cholangiocarcinoma. These biomarkers are unspecific. They are commonly found elevated in patients with chronic biliary diseases. And in this large European study, we investigated their sensitivity in patients with local disease, locally advanced with lymph node invasion or metastasis for all three cholangiocarcinoma subtypes. As you can see, the levels of CA19 and CEA, the median value is below the upper limit of normality for all cholangiocarcinoma cases, intrahepatic, perihilar, and distal, when the disease is local, when it's very small tumors. However, when the patients presented an elevation of these biomarkers at diagnosis, this was associated with a higher risk of presenting disease dissemination in the lymph nodes or metastasis. So it's a marker of staging more than a marker of early detection. In fact, in patients with an elevation of CA19 and CEA at diagnosis, they were associated with a higher risk of presenting metastasis compared with individuals with a single elevation of any of these two biomarkers. So when a patient presents an elevation of any of these two biomarkers, we should definitely conduct a positron emission tomography for a proper disease staging. And another caveat of CA19 or Lewis antigen A is that it is not expressed in about 10% of the general population due to a mutation in the FUT3 fucosyl-transferase enzyme necessary to generate the antigen. So this is really important. So again, these two biomarkers are markers of staging particularly, but we also found in a large multivariate analysis that CA19 is an independent prognostic marker, together with the ECOG performance status and the disease stage. Also, it has been shown that the levels of CA19 correlates with radiological response and overall survival in patients receiving GemFi. So it could be a potential marker of treatment response. We need to investigate the role in other current treatments. So who should be the target group for screening and early detection? It is important to highlight that most of the patients have an unclear etiology at diagnosis or an unknown etiology. However, there are several factors that highly increase the risk of cholangiocarcinoma development, like the presence of cholecalciferous, gallstones, cirrhosis, chronic biliary diseases like Caroli or primary sclerosing cholangitis, hepatitis B or C viral infection, and certain liver flukes, like Orpistorchis viverrini and Clonorchis sinensis, which are endemic in certain regions of Southeast Asia and responsible of the high incidence of this cancer in those areas. These are high-risk factors, but in general, they are low prevalent. On the other hand, we have other factors that induce moderate risks, but that are highly prevalent, like alcoholic liver disease, type 2 diabetes, tobacco, or MASLD. Aging is another important risk factor. The median age at diagnosis, according to the data from the global BTC registry, is 66 years, and 75% of the patients presented more than 58 years at diagnosis. And last but not least, there is a proportion of cases, around 5%, that show germline mutations, so inherited mutations, in different tumor suppressor genes that increase the risk for the development of different types of cancers, including cholangiocarcinoma. So you can see the wide variety of risk factors. But what is interesting is that the majority of those risk factors that induce moderate or high risk are factors that induce chronic liver injury. We have also two groups that induce high risk, which are individuals with minimal residual disease after surgery. These are people that have risk of recurrence, and also individuals with inherited mutations. So here in this study, we try to investigate what is the clinical course of patients with cholangiocarcinoma with a healthy liver or with chronic liver disease. At the beginning, we hypothesized that maybe patients with a cholangiocarcinoma and a diseased liver would probably perform similar or worse. No? This is a hypothesis, no? But interestingly, well, we explore the global BTC registry with more than 6,000 cases at that time, and we were able to identify almost 1,000 patients with cholangiocarcinoma and chronic liver disease. You can see individuals with cirrhosis, PSC, steatosis, particularly steatopatitis, hepatitis B or C, viral infection, and PBC. And then we match that group with almost 3,000 cases with cholangiocarcinoma and an apparent normal liver. Interestingly, most of the patients with chronic liver disease present intrahepatic cholangiocarcinoma. And these patients, as you can see, perform better. They show higher overall survival compared with individuals with a healthy liver. So with a median overall survival ranging from 11 in the control group to 14 months in the group with chronic liver disease, and showing higher 1, 3, and 5 survival rates. So we saw this data and we were, wow, this is very interesting. Probably they respond different to treatments, but a liver who is with a disease shouldn't respond better. So we evaluated the performance of both groups in patients undergoing surgery, active palliative treatment, mainly with chemotherapy, and best supportive care. And as you can see, they show the same performance. So what's going on? What is behind this increased survival? So we evaluated the characteristics of the patients at the diagnosis. And as you can see here, in individuals with chronic liver disease, the disease is diagnosed in an earlier stages. So the disease is more local at diagnosis compared to individuals with a healthy liver. And they are more prone to receive surgery. And that's the reason why they show higher overall survival. So, but in the database, we have information of the patient at the moment of the diagnosis of cholangiocarcinoma. So we didn't know if the identification of the chronic liver disease before and certain degree of surveillance is behind this early detection. So we evaluated the registry and we identified a number of cases where the chronic liver disease was actually diagnosed at least 6 months before the cholangiocarcinoma detection. And then we matched with a bioinformatic analysis with propensity matching score with another group with the same clinical and demographic conditions, but with a healthy liver. And indeed, we found that patients with a pre-existing chronic liver disease are more likely to be diagnosed in early stage cholangiocarcinoma. So these data support structured surveillance programs in individuals with moderate and high risk factors, and particularly to investigate on more accurate early detection tools. So what is liquid biopsy? Liquid biopsy is a new concept that arose a couple years ago, and basically it's a minimally invasive approach for biomarker discovery, including the isolation and analysis of cell-derived materials from blood and other biofluids. So in the next slides, I will focus on 3 strategies. One is the analysis of the metabolome, the metabolites that are in circulation in bile, then on extracellular vesicles, and circulating tumor DNA. So one of the main risk factors for cholangiocarcinoma, particularly in Western countries, as mentioned, is primary sclerosing cholangitis. As you know, this is a chronic cholestatic and immunomediated liver disease characterized by the development of multifocal fibroinflammatory strictures. The etiology still is unknown, but seems to be closely associated with a prior development of inflammatory bowel disease, mainly ulcerative colitis. Individuals with PSC face a cumulative cholangiocarcinoma incidence between 15–20% in 20 years, but this is not related to the PSC disease stage or the grade of fibrosis. The current surveillance tools by imaging of CA19-9 are suboptimal, and still cholangiocarcinoma is the main leading cause of PSC-associated mortality. So we have good imaging modalities to diagnose PSC when the disease is well established. However, current imaging techniques do not allow to identify the disease to confirm when the disease is in the very early stages or when it affects the small bile ducts, where biopsy is necessary to confirm the diagnosis. Moreover, we don't have biomarkers to stratify cancer risk and also the differential diagnosis of those structures between benign and malignant. So, based on a previous collaboration with All and Rubio Metabolomics and a large group of international centers, we found that, for example, in patients with muscle D, with fatty liver, they present specific metabolomic signatures in serum that might allow the diagnosis of muscle D and the different stages of muscle D, simple steatosis, MASH, and MASH with advanced fibrosis. And based on that, we commercialize a test that is now in the United States and in Europe under use. So based on that, we wanted to explore how this methodology could be useful to diagnose PSC and early cholangiocarcinoma in individuals with PSC. So we initiated a large international study with 13 healthcare centers from 8 countries, and we were able to recruit more than 400 patients with PSC and PSC cholangiocarcinoma, thanks to the collaboration of all of these centers, but particularly to PSC supports in the UK and PSC partners in the US. So we profile the serum metabolome of all the patients. We identify around 500 metabolites, commonly found identified in all of them. And we found a signature of just 6 metabolites that within a logistic model, and independently of all of this clinical information, so the presence or not of IBD, inflammatory bowel disease, the sex, the age, the presence of not of cirrhosis, the treatment or not with UDCA, and independently of markers of cholestasis of liver injury, they show very high performance for the diagnosis of PSC in discovery in an validation cohort compared to a healthy control group. As expected, this signature didn't allow to differentiate individuals with isolated ulcerative colitis or healthy controls, and in a sub-analysis, we found that the performance of the test performs very highly and similarly in individuals with PSC with IBD, without IBD, or even with cancer. So everything beyond 0.90. So this could be a potential useful tool to avoid biopsies in unclear cases, and particularly in cases with overlapping syndrome with autoimmune hepatitis or in cases with the subtype affecting the small bile ducts. It could be also a useful tool for patients for PSC screening in patients with biliary stenosis or in patients with IBD, inflammatory bowel disease. In addition, we identify a signature of 6 metabolites that, again, within a logistic model and independently of all clinical variables mentioned before, and also the cholangiocarcinoma subtype, that show very good performance for the very, very early detection of cholangiocarcinoma with an area under the curve of 0.95, compared to CA19-9 that show no diagnostic capacity for these early lesions. We then evaluated the performance of the test in individuals with low CA19-9 and cholangiocarcinoma, and as you can see, the performance of the test performs and maintains very high. So this can be a useful tool for screening, cancer screening in individuals with PSC. Now we are nowadays evaluating in a blindly way more than 600 samples from patients with PSC, PSC cholangiocarcinoma, and many control groups with secondary sclerosing cholangitis, IgG4, PBC, and the plan is to, if we confirm the results, we are working with the PSC partners and PSC support in parallel with the different advocates and lawyers to try to conduct all the regulatory phases for hopefully some approval and implementation into the clinic. Another strategy in the search of biomarker is the analysis of extracellular vesicles. What are extracellular vesicles? Well, these are small membrane spheres secreted by all the cells into the extracellular milieu and found in all biological fluids. They contain different biomolecules, and in particular, they contain proteins. So here, what we did was to isolate extracellular vesicles by ultracentrifugation from 1 milliliter of blood. And then by proteomics, we characterized the protein content. Then we selected some proteins that were found elevated in these vesicles and validate the results by using a simple ELISA and using total serum with the need to isolate the vesicle. So this is a heat map that shows the differential concentration of proteins in patients with cholangiocarcinoma in the extracellular vesicles compared to healthy individuals or patients with PSC. So you can see that there is a large change in the protein content and concentration in the vesicles from patients with cancer independently on the etiology of cholangiocarcinoma. As you can see, few proteins are dependent on if the patient is from PSC etiology or non-PSC etiology. And this is very good because we can select single biomarkers for all kinds of cholangiocarcinoma cases independently on the etiology. So we focus on those proteins found with an elevated concentration, and we identify those proteins with available ELISA, commercial ELISA, and then try to validate as a proof of concept using total serum in this case. So once we identify the candidate, then we take the total serum and a simple ELISA. So we've chosen 7 proteins related to inflammation, coagulation, and cancer, and all of them here you can see in the brown dots in the right side of each panel, all of them are elevated compared to patients with PSC or healthy controls. And this elevation, again, was independent on the etiology, PSC or non-PSC. Based on that, we developed some bioinformatic modeling, and just the combination of 2 proteins, C-reactive protein and the ferritin light chain, show very high performance for cholangiocarcinoma detection, beyond 0.90 in both discovery and validation, and when we stratify the cases in very, very early cases, it was also very high. So, can these biomarkers of early detection could be useful to predict cancer development in patients with PSC? So we analyzed the levels of these 7 proteins in patients with PSC who developed cancer in the follow-up. So we got a blood sample before the developing of cancer, and within a range of 2 years, we analyzed the cancer development, and we compared with individuals with PSC who didn't develop cancer in more than 5 years of follow-up. And as you can see, there are 4 of the 7 proteins were found indeed elevated in patients with PSC who developed cancer afterwards, but before any clinical evidence of malignancy. So they could be potential predicted biomarkers for PSC. In PSC patients for cholangiocarcinoma. And these biomarkers are specific of cholangiocarcinoma. We compare their levels in individuals with intrahepatic cholangiocarcinoma compared to hepatocellular carcinoma, and you can see that all these 7 biomarkers are elevated specifically in intrahepatic cholangiocarcinoma, and the combination of just 2 proteins show very high performance. So this is a large international effort that, again, with the collaboration of PSC partners and PSC supports, we are now validating in more than 1,000 samples, including a large number of control groups and samples from all over the world. So another strategy is the analysis of circulating tumor DNA, which is basically, these are small fragments of DNA released by cancer cells under cell death. And they are found in most biological fluids. You can find in blood, in bile, particularly for biliary cancers, and even in urine. There are strengths and limitations of this technique. It's quite new, so they can be useful to identify circulating tumor mutations suitable for targeted therapy, to monitor the tumor evolution, the mutational tumor evolution during follow-up or treatment, to identify new forms of resistance, to identify mutations from different tumors in the human body, and also to identify minimal residual disease or early recurrency after complete tumor resection. But still there are limitations, particularly the low fraction of circulating tumor DNA compared to the whole cell-free DNA in the blood, for example, and also by the fact that mutations are not only specific of cancer, they can be found in patients with chronic liver disease. So still there are concerns about these techniques in terms of sensitivity and specificity, and there is an intense investigation. The analysis of the role of ctDNA has been investigated in PSC. This is a recent study, and you can see that they included 63 patients with PSC without cancer and controls. They identify mutations, so positive ctDNA, in 2 controls. So you can see it's not specific of cancer. But 1/3 of the patients with PSC without cancer, they show positive ctDNA in blood, so they show mutations in blood, because these patients present different degrees of dysplasia in early or in advanced phase, that not always progress to cancer. It's something even reversible. So they included 4 cases of PSC and cancer, and they identified ctDNA in 3 of them, but not in 1 of those. So this indicates that there is no association between the number of mutated genes the mutant allele frequency or the follow-up time between the sampling in the PSC patient and the development of cholangiocarcinoma. So with this data, we can say that we need more research to try to understand if ctDNA could be a useful tool for patients with chronic liver disease, but for the moment, it's not. A niche where ctDNA could be useful is in order to identify minimal residual disease after surgery. This is a very nice study published last year. This is a clinical trial for extrahepatic cholangiocarcinoma in patients with complete tumor resection following adjuvant treatment with capecitabine of Genthis. They found that after surgery, those patients who were ctDNA positive, they show lower disease-free survival. But when those patients were treated with the adjuvant treatment and the ctDNA turned to negative, so disappear, these patients show increased disease-free survival, indicating that the levels of ctDNA and the dynamic changes can give us information on the presence of the disease and on the progression or disappearance. So this is, I think, very interesting data. So in conclusion, I tried to show you that there are novel liquid biopsy strategies emerging for biomarker discovery with potential for disease diagnosis and staging. However, it's very important after the first discovery studies to use appropriate clinically controlled groups with biopsy-proven diagnosis, as well as representative number of samples to validate their accuracy. And we need to investigate also on different cohorts beyond PSC, those groups with moderate or even to high risk, and identify biomarkers of treatment response. And the most difficult part, try to work all together with the patient association, with the whole community, to try to translate this into the clinic, to try to follow all the regulatory path to really put it into the hospitals. I want to thank the different institutions that support our studies, my team in San Sebastian, collaborators, and of course all of you for your attention. Thank you very much.